This is very useful, and we've got quite an array of both conceptual and very practical issues that have been raised, and we've got about 20 minutes or so for discussion with the workshop participants. So we can leave the mics open for anybody who's got a question. The theme of this session is essentially under what conditions can these representations of a real world problem end up producing a productive engagement. And we've got quite an array of conditions in play here. There's the conceptual and philosophical to how do you actually get people into a place where the urgency of their daily lives actually give them the space to think about a problem and maybe discover that there isn't as much controversy as one might have thought. Maybe just to get the conversation going, it'd be interesting to say a little bit more about how the party politics ended up turning into a more productive conversation. Karen, you mentioned that conversational capacity is one of the skill sets here, and we've described. We spend a lot of time thinking about models and what they do, but not so much about the conversation that surrounds them. So maybe you can say a little bit more about why that's an important skill set and how that plays out in the ideologies that people walk in the room with.
I think the conversation capacity has been, in some ways, one of the favorite parts of this in a way, because having that conversation and being able to be in disagreement but yet still come to some productive outcome has been really important. I remember the first time when we did the stock and flow diagram about moving from being at risk to being healthy, and the legislators were talking about, well, what would you do to move from being at risk to being healthy? And they said, well, you would lose weight, you would stop smoking, you would exercise. And one of the legislators said, well, I'm morally opposed to the government paying for an individual to lose weight. And one of his colleagues in that same session said that the thing I said before, well, the way I see it, Charlie, you can pay me now or you can pay me later, and if you pay me later, you're going to pay me more. And so they ended up choosing that as the title of the session, Pay Me Now or Pay Me Later, that they did with the larger legislative body at the biennial. And that was the session where Representative Cooper shared the results from the model and called on her colleagues to implement the policy that ended up getting passed. I'm sure there were other discussions that occurred.
One of them was...
Yeah, there you go.
One of the things was, as we went through all of my thing, is that we realized we needed to find a better way to talk to each other during session. And I'm guilty as anybody, because you come up and all the bills are going. I remember one when somebody came up and wanted me to move a bill that would say that nobody could donate your organs after you were dead. If you hadn't signed it away, families couldn't do it. And Georgia has a terrible rate of organ donations already, and that would have put us and knocked out about 70% of them. And I just turned around and yelled at him. There is no way that bill is going to pass. And of course, then it was just a big eruption, and he was a Republican. One of my colleagues did it, but I just wasn't going to hear it. And you get that emotional, and things get so busy in session. So we asked for a special session on how to communicate. And they brought in a really great person to teach us how to listen to our colleagues in a different way, to find their sweet spot, so that we can communicate. And so I think it's been very helpful, too, on adding that. So they've listened to us when we felt like we needed other aspects of the program.
Pam.
Hi, Pam Russo, Robert Wood Johnson Foundation. Earlier today we were talking about how it would be great if you could bring all the stakeholders and the experts together to build the model. And it sounds like, from the way you described the Learning Lab, did you really just bring them all together in the morning, and by the afternoon you had a model to work with? And then the second question to Ms. Cooper is, so did you actually show the model in the legislature? So two questions.
Well, I'll say The building of the model, and Rachel led this process, and she swears that she won't ever do it this way again, was built between August and December. And so the experts, the legislators, the staffers, and the translators, and the ones doing the research and actually building the model met periodically over that several-month period to scope the problem, decide the priorities, do the background research, test what was coming out of it, and then in December we presented it. You might want to say a little bit about what we did do a single session with the legislators, but you might want to say a little bit about what the biennial is and that session where you shared it at the biennial.
The biennial, every 2 years after the election, because we run every 2 years, Senate and House both, we go to Athens, where they have the University of Georgia, and in their continuing education department, and have our biennial session. And what we have, it's 3 days, and we will have talks about what we think the major issues coming up during the session will be. And then sometimes there's breakout sessions, sometimes not. And so that year we had one about obesity, and that we were going to bring up that bill again because of what happened the year before when the one went down in flames. And I was able to share with my colleagues, and we did use part of the model for them to actually see it and talk about it and tell them what had happened and how we had come to this conclusion. And it was different in United States because the year before, we don't usually have visuals on the floor of the House. We do have screens, and you can put something up, but not usually. And when the year before, when it had failed, the young legislator that had presented it had visuals of our state and where the obesity was and how 10 or 20 years before it'd been, this was how much obesity we had, how much we had in the last 10 years, where we were now, and with the projections of where we were going, the whole state was just going to be dark red and everybody was going to be obese. And it still went down in flaming things. But being able to talk to them about it and explain how a group of legislators came together and came to this conclusion seemed to make the difference. It was quite the buzz, in the evening and at dinner and this kind of thing, and we had no trouble passing the bill the next year.
Rachel?
Hi, I'm Rachel Forensic with the Georgia Health Policy Center, and I just wanted to make a follow-up comment that I really believe that I think the legislators were able to use the model so successfully and be better consumers of it because of a lot of the information that they were given in the sessions preceding that. So through the 6-question framework and the behavior over time graphs and the stock and flow maps, I think they were able to consume the model use in a different way than if we had just shown up one day with a model and said, here, use this.
Mm-hmm. Sure.
We're not as contentious as Washington. There is still some, we have some fights and so forth, but I think the fact that it was bipartisan and the legislators that took part that were Democrats went back and talked to the Democrats in the time before we went back into session, and we went back and talked to our Republican colleagues. So the word had sort of gotten out to both sides on the issue. And of course, obesity affects both issues. It's not, it's not partisan, and we needed both sides, especially after the way it had gone down the year before. We thought we were going to need every vote, which we didn't. We got an overwhelming vote for it, but that way both parties had heard from people that were actually in the process ahead of time.
Mm-hmm. Please.
So the experience in Georgia seems very innovative and exciting, but can you discuss how but it seems also to be kind of a bilateral conversation between the knowledge producers and like the legislature sort of decision makers. There are other political constituencies that are going to affect the opinions of the legislators. And so how might, so is there an inside-outside strategy that you're envisioning where you can bring the same sort of information, knowledge tools, information to community constituencies that might help move things in ways that might not be achieved just with that kind of bilateral discussion?
Mm-hmm. That's a good question.
Do you want me to, am I not
well,
clear?
We've talked a lot about how could this model perhaps be used with state boards of education, local boards of education, because a lot of it points to the value of physical education in schools. I don't know if that's what you're thinking.
I guess I'm meaning voters, advocacy groups. I mean, people who are working to influence the decisions of legislatures. I mean, I'm wondering if you're triangulating.
It's interesting that you brought that up, because when I first went to the Woodruff Foundation to make the request about the funding, I asked for more general funding, for there to be this kind of system thinking among any stakeholders in health. And the Woodruff Foundation said, if you can have that kind of success in the legislature, we'll pay for it. And I didn't really know if we could or not. So it was really the funder push to have it focused on the policymakers when we originally were thinking about a broader group of stakeholders. Although with the Rethink Health model that we used with the Atlanta Regional Collaborative for Health Improvement, that was a few county commissioners, mostly lay and healthcare, a lot of very multi-sector group, about 75 people who used that model. So we have had experience with using models and maps and these tools in a lot of different settings. I think we've just mainly focused today on the policymaker side of that work.
Michael.
I don't know about other legislators, but I think there's a large number of us that are tired of being pulled apart on both sides of the film. I think there's people on Democrats that don't like their far left, and I know I'm sick and tired of some of the people on the far right. And personally, just like the lobbyists, at first they wanted to come. They wanted, remember that? They wanted to participate. And we said, no, this is for legislators where we can talk and we don't want the lobbyists there. I mean, we're sent down to make the best possible judgment we can make, not what just a group of people want. And I think there's real value in us discussing it among ourselves and trying to learn and get the information on our own and without the groups that are biased one way or the other and that have become very contentious. And I like it the way it is. I'm sure there are some issues that, you know, would need both, but it's sort of like CON. The hospitals are so against it, it's almost impossible. I mean, they hired 80 lobbyists against it, and the independent docs and the people that want it are on the other side. And I've been in those meetings, and you don't get anywhere. So it ended up, the legislators, we decided what they were going to get. There were 5 of us that sat down after 2 years of fighting over this and sat in a room and decided, okay, here's what we'll give them. And we really, in the end, because neither one of them would move, so I think there's real value to keep it just for us.
I actually wanted to ask you guys a question, maybe Representative Cooper especially. This is actually in light of discussions we're having this morning in our breakout group. So the really good modeling practice often yields a lot of uncertainty, because the more realistic you are about what you've actually learned from the model, you know that, well, I can tell you this much, but no more. And then some of this is going to depend on factors that we don't have a handle on yet. So I'm curious, I mean, did these kinds of issues come up? And if they didn't, I mean, as someone trying to make good law, how much ambiguity are you willing to tolerate?
Well, if you have no background in an area, and
Well, you have background in the area.
well, I know
Yeah.
just me, but I'm only one person, and I have to try to get my committee to either stop bad health legislation or to move it forward. And I'm basing that on my judgment. I mean, I'm the worst person in Georgia right now. I mean, I've been hit that I morally don't care about patients. Georgia has a rare opportunity. Our PAs and nurse practitioners cannot give Schedule IIs. And on October 6th, they could give Schedule IIIs, which included hydrocodone. On October 6th, the federal government put hydrocodone into Schedule IIs. So that meant that all the PAs and all the nurse practitioners in Georgia could no longer order hydrocodone. We have seen a major drop in the number of prescriptions written from October, to the end of the year and going forward. There were 4.5 million prescriptions written for hydrocodone in the state of Georgia last year. We have a drug problem and an addiction problem of opiates, and it's everywhere. So don't grin thinking it's just Georgia. Consumer Reports it was on September, on their front cover and all, how Americans consume 96 or 97% of all the hydrocodone made in the world. We have an addiction problem. So we had this rare opportunity, because many states, the PAs and nurse practitioners can already give twos, so it didn't affect them. So we had this rare opportunity to study it. And I want to study it. And so last Thursday night, they tried to attach that bill to everything, and I stopped it. And so now they're all after me because they're saying, I don't care about patients, and there's nothing further from the truth. We don't have any patients dying from not getting hydrocodone. Is it inconvenient? Yes, but we'd already passed about pill mills. And so we have this window to see if this was a fluke, the drop, or it's going forward. So, I'm just one person and trying to influence people. And now I've forgotten what the question was.
No, I was saying one of the issues that we who make models face when talking to people making decisions is that,
ambiguity.
Yeah, that we know, we can say, well, here are the things that could happen given the scenarios you've told me.
Well, I would say that and they did on these studies, they only used research that was good research to put in the model about obesity, and that they could find that had been published. And I think that's a whole lot better than just, here again, that's based on my opinion and one doctor in the Senate that we think that we can make a difference. We may be wrong. It may be a fluke, and they may not be the ones that were ordering the most of it, and we may find that the doctors just up the amount they give to make it more convenient. I don't know, but we have a chance to look at it, but I could be wrong. So I would take my chances on modeling that could be not perfect, but I would take my chances on modeling from just my opinion or no information. And we have very little research staff, and I would bet you that most legislatures are like that. I mean, we don't have 10 people helping me on health. My researcher covers 2 other committees besides my committee. And so during a 40-day session, there's just not a whole lot of time if something new comes up. So I'll take my chances with the modeling, even though I have no idea, even after day, how it possibly happens in that computer. But and somebody in our group, we talked about resistance to it. If you look at the age of most legislators, we're in that group that didn't deal with computers. So I think if there's a little bit of a resistance against it, or saying, how does it really help you? It could be because of our age and not really being in that computer.
Mm-hmm. I think we have time for one more question. George?
So my question has to do with generalizability of this relationship. So I've gathered from the presentation that it's really important that you have the curriculum and you're training legislatures. And I've picked up from the conversation, you can tell me if I picked up the wrong thing, but there's definitely the opportunity to veto what's in the curriculum based upon, the beliefs of the people that are involved, and so there's interaction with the legislators in terms of the curriculum. And then, and it seems like it's a very impressive model of the use of information in a different way with some of the very important realities of legislating. And very impressive, your leadership, Representative Cooper, in terms of this. So my question speaks to generalizability of this sort of system to other legislatures. And then secondly, generalizability of this to other policymakers in the sense that we were talking about it in the last session. So private policymakers, say boards of directors of not-for-profit hospitals, or say that administrative class of leaders that are emerging as heads of these new ACOs that federal legislation is causing. So if you could just speak to that, that would be just
I'll say a little bit. Representative Cooper was saying to me, she said, we don't have say in the content. And really, we do pretty independent. The topics are chosen, but what is presented about the topics is a pretty neutral information. After we had been doing this a while, we had a lot of questions from some of our colleagues in other states, and so we offered a program where we invited people to come from other states, and we suggested that they bring somebody who was either a legislator or closely tied to the legislature, someone who was from a place like the Health Policy Center who could actually be the convener of such something, and a funder. And we had 8 states that came and spent a couple of days with us and talked about what we shared, what we did, and they talked about what they might do. We really began to understand that you might design this a little differently depending on how much staff there is, what are the situations with term limits, what's the balance of power between the administrative and the legislative body in various states. But several states, South Carolina implemented a program very similar. Colorado took a component of the program. Kansas added to a program that they already had, a systems component. And we've had a number of folks in our conversations recently with the Milbank Foundation states. They ask us to share about this. So I think there is the opportunity, given having the legislative buy-in, a vehicle, and the funding to do it, for it to be replicated and for us to build more capacity like this in other states. I also think that it's possible to do this kind of work with any kind of group. At the Health Policy Center, we have we're the administrative home for a group called the Philanthropic Collaborative for a Healthy Georgia, and it's foundations who want to fund health. They sometimes put their money together, and we manage the programs for them. But before they decide what they're going to do with their money, they ask to go on a learning journey about the topic. And very frequently, their learning journeys are similar. It's maybe 6 months, a half a day each month, and they learn about whatever it is, and then they decide, do we want to fund independently in a different way? Do we want to fund together? Do we want to put our money together? And how do we want to do that? So the other thing is that we've gotten questions and requests from the administrative branch of our government to be present with the legislators. And so far, we decided that while we would have the administrative branch make some presentations, like about public health, that we would not have them in the course, in the certificate program, and we have developed tailored, abbreviated certificate programs for, like, the deputy of Medicaid or the governor's office of budget and policy folks, and given them the similar content in a tailored, abbreviated way, but not in combination with the legislators.
Maybe just one more thought.
Okay. I just wanted to say that I think that legislators are hungry for knowledge. They may not ask you, and I think they probably don't even realize that we can go to our state schools. I mean, we fund Georgia State. We fund the University of Georgia, and that's the same way all over this country, that we, that we pay for their existence. And there's that body of knowledge sitting close to us. Now, thank goodness we are in Atlanta, and Georgia State's right in our back door. But I think that legislators don't realize that we can even use that body of knowledge there. And it's amazing, and I think that's one of the best things that's come out of it, to realize that they're a resource that we can use and we can learn. Because I think legislators are hungry for knowledge as problems become more complex, and they are what we're facing today. Very complex, especially in health, with the changes in the healthcare system and all. It's above most of our knowledge skills, and even in other areas in the legislature, and trying to make the budget work. But in other areas, I think that just knowing it's available, and maybe other states need to take use of what's available to them, and just haven't thought about it.
That's a great note to end on. And I think it's really impressive that I'm going to walk away with the sense of ownership that this process has developed, in the sense of the members and the various contributors to this process all actually doing something that is sort of larger than any one of them, and dealing with one of the most intractable decision points in our whole landscape is what a legislature does. So thank you all. We'll stop now, and we have a break, I think.